Greeting, I am Dr. Amr, and I will continue our previous lecture about airway evaluation and management. We already discussed airway anatomy, then we discussed the evaluation of airway by taking history and examination. Then we discussed different instruments available for managing airway, like oropharyngeal, nasopharyngeal airways, their indications, their complications, then laryngeal mask airway, and endotracheal intubation, different endotracheal tubes, indications for endotracheal intubation, complications of endotracheal intubation, and the procedure how we do step-by-step intubate the patient. Then we discuss fiber-optic bronchoscope. Now in this lecture, we will discuss other instruments for airway. Light wand is a stellate, is a microstellate with light emanating from the distal tip, over which endotracheal tube is inserted or slide. We manage the patient in a dark room and we search for the glow of the light. If the glow is in the lateral neck, that means the tip of the light wand is in the piriform fossa. Now, if the glow is in the anterior neck, and that means we are correctly positioned the light wand and we advance the endotracheal tube to the trachea while pulling out the light wand. Now, if the glow is diminished or we can't sit on the neck, so that means we are in the esophagus and we should take it out and try again. Light wand is an instrument for difficult airway management and it is available here in the city. This is a picture of light wand, and this is, as we see, stellate, the glow in the tip. Here we slide the endotracheal tube and fix it, then we introduce it blindly inside patient mouth. Video laryngoscope. Video laryngoscope is just like an ordinary laryngoscope. Has blade, a handle, but instead of direct vision through the patient mouth, there is a camera that's on the blade and we can do endotracheal intubation while we are watching through this small monitor. This is another picture for video laryngoscope. In this picture we see the video laryngoscope and different size blades. Also there is another one, we can connect it to our cellular phone. And this is how we insert it as ordinary endotracheal tube. We get it by our left hand, then we insert it gradually, go inside from the right side of the patient mouth, then to the middle, and under camera vision, under video vision, we insert the endotracheal tube. This procedure, this instrument, gained special interest, especially during the corona virus COVID-19 those days, because we don't need to see immediately through the patient's airway, so the chance of infection is much less for the patient who is doing intubation by using this video laryngoscope. Retrograde tracheal intubation. Now we finish with the instrumentation, and now we are going for invasive procedures, interventional procedures for endotracheal intubation. The important thing that retrograde tracheal intubation is not for emergency or when the patient is dying or during resuscitation. It's for elective endotracheal intubation, that we are patient, we expect difficult intubation and has elective surgery or non-urgent surgery, and we want to do intubation for him. The patient is awake and he can breathe spontaneously, so under local anesthesia we puncture the cricothyroid membrane with a large gauge needle and introduce a wire guide. This wire guide advances gradually until it comes out through the mouth. Then we can slide endotracheal tube either blindly or with direct laryngoscope through the mouth, sliding over this guide wire and to the endotracheal tube. Then we remove the guide wire. We see those pictures. This is the guide wire. Sometimes we connect to this guide wire a bougie. This black is a bougie. Okay. Then when we pull out the guide wire, the bougie will be inserted in the trachea, and over this bougie we insert the endotracheal tube. This airway bougie can be used in retrograde endotracheal intubation or just alone without invasion. They're just inserted inside patient mouth, then larynx to the trachea, and we can slide the tracheal tube on it. So it could be solid or hollow, as we see as you saw in the previous picture. It's a bougie is still lit and usually pass blinding to the trachea. Sometimes even we pass it under vision of laryngoscope. What's the benefit of bougie? In the bougie, we don't need the patient to open his mouth fully as we need in the endotracheal tube, and also we don't need to move patient neck. So maybe it's a good method for difficult intubation and for patients that we cannot move their neck because of the C-spine injury during car accidents, after car accidents. This internal lumen or hollow, we can use it also for giving oxygen, to separate oxygen or detect CO2 through it. This is the bougie. And this is endotracheal tube slided over it. Endotracheal tube and bougie. When everything's failed and we have emergency and we want to do emergency airway management, all the instruments failed, endotracheal intubation, laryngoscope endotracheal intubation failed, so our last choice is cricothyrotomy. Cricothyrotomy is an emergency procedure for opening airway for a patient. It's better to not be used for patients below 6 years because the upper part of trachea not fully developed, and incision through the cricothyroid membrane could increase risk of stenosis in the future. Sterilize the skin and identify the cricothyroid membrane by going over thyroid cartilage and go down in the midline of the neck until we feel some softness just below the thyroid cartilage, and this is the cricothyroid membrane. Transverse incision 1 centimeter on each side of the midline. Then by the back, when we put a cut, by the back of the scalpel, we rotate inside the wound so we make it bigger that we can introduce our endotracheal tube. Insert endotracheal tube and inflate the cuff. Confirm breathing sounds by stethoscope or chest rising when we are using ambu bag. In this picture we see where we are identifying the place where we cut for cricothyroid membrane. We identify the place, we cut down and we search for cricothyroid membrane place. Then we do another cut in the cricothyroid membrane, and as we said, we enlarge the place length for endotracheal tube by the back of the scalpel, and we insert the endotracheal tube inside and check bilateral. Now we talk about another important subject, which is oxygen therapy. Different instruments available for oxygen therapy for the patient. Why patient needs oxygen therapy? Patient needs oxygen therapy because of the hypoxia. Hypoxia means partial pressure of oxygen in the blood in the arteries of the patient is less than 60 millimeter mercury. Usually we don't, this needs a blood gas analysis, and we don't do that. We depend on pulse oximeter. Pulse oximeter when it's less than 92 or 90, so the patient could be in hypoxia. So what we do, patient hypoxia, we give oxygen. Sometimes we supply oxygen even when there is no hypoxia as a routinely post-operative procedure. This may prevent hypoxia in the post-operative period. And sometimes we supply it during some procedures like endoscope. Also we supply oxygen in labor sometimes. So oxygen therapy has different indications. In the presence of chronic obstructive pulmonary disease, the patient will need different concentration of oxygen, not high concentration. We need to decide how much oxygen we should give the patient. And in those patients, also we need to take care about or decrease the carbon dioxide retention. So we use a special instrument we call Venturi or Ventimask, which we'll discuss later, and by this we can control the amount of oxygen going to the patient. The first instrument for oxygen therapy we'll discuss is nasal cannula. Nasal cannula gained those days because of COVID-19 some importance because they are using it now in high flow instead of ventilation. Really, it's not instead of ventilation, but this high flow oxygen could decrease the chance for the patient to go on ventilator. So nasal cannula supplemental oxygen can be administered through a nasal cannula with a minimal patient discomfort. The nasal cannula incorporates two prongs that extend about 1 centimeter into the patient's nares and is held in place by an adjustable elastic head strap. This is a nasal cannula. Here connected to oxygen source, and those small opening are going inside patient nose. Inspired oxygen concentration achieved with nasal cannula depends on the flow rate of oxygen through the flow meter. That means higher rate, higher oxygen. Patient tidal volume, how much patient can take a breath. Breathing frequency and volume of the nasopharynx area. This picture shows how the nasal cannula inserted. This nasal cannula, and here is connected to the oxygen source. Oxygen flow rate at 6 liters per minute gives inhaled oxygen concentration about 44%. Excessive flow rates of oxygen may result in air swallowing and gastric distension without increasing inhaled oxygen concentration. Multi-breathing does not decrease the effectiveness of oxygen therapy delivered by nasal cannula because inspiratory airflow through the posterior pharynx entrains oxygen from the nose. The problem with nasal cannula that we can't use a very high flow rate because very high flow rate could be discomfortable for the patient and lead to dryness of the nose. The advantage, as you see, the advantage of nasal cannula, that the patient can talk, eat, watch TV while he's receiving oxygen. It is more acceptable by pediatric age group especially because it's not big, does not cover their mouth in compared to oxygen mask. So it is more acceptable and it's very common, available in all the hospitals. Face mask. The face mask oxygen, okay, have 4 types: simple, partial rebreathing, non-rebreathing, and air entrainment. We call it Venturi. Those are different face mask pictures. We see simple face mask, also we call it as a mask, or partial rebreathing, non-rebreathing, and Venturi mask. Simple face mask, it does not include a valve or oxygen reservoir bag. It's just a mask we put on the patient's face. It can provide inhaled concentration of oxygen between 35 to 50, which is good, with O2 flow rate around 5 to 8 liters per minute. Provide little advantage over nasal cannula. That means nasal cannula we can give around 44, here we can give 50. In terms of delivering constant inhaled concentrations of oxygen. But of course, it's disadvantage that it's not acceptable by every patient. Patient cannot talk freely or cannot eat while the face mask is on his face. It's difficult for pediatric to accept this face mask on their face, so it has its own problems. But the advantage, it can give us higher concentration of oxygen than nasal cannula. This is face mask. Also, it's available in all hospitals. Partial rebreathing mask, oxygen mask. It's a valveless system. It's just a mask and a reservoir bag with oxygen flow up to 10 liters per minute. We can reach 50 to 60% oxygen. So this is mask and a reservoir bag where the patient can take oxygen or reserve oxygen in it. In this picture, we see partial rebreathing mask. Partial rebreathing mask consists of a mask and an oxygen reservoir bag. Non-rebreathing mask. Non-rebreathing mask includes a face mask, unidirectional valve, and the oxygen reservoir bag. Inhaled concentration of oxygen can reach 100% through this mask if it's fixed tight on the patient's face to completely eliminate air entering from the room air entering through it. The flow rate of oxygen into this system should be sufficient to maintain an inflated reservoir bag. How much we give oxygen through this bag? We can reach 100% if we open enough flow that the reservoir bag can be inflated. This is the picture. Face mask and the valve, you can't see it here, it's here between the face mask and the reservoir bag. And this is oxygen, this tube for oxygen source. Air entrainment or venti mask, or sometimes called Venturi face mask, it depends on Bernoulli principle to entrain large volume of room air to mix with oxygen flowing through an injector. The result is a mixture of gases produces stable inhaled concentration of oxygen between 24 to 50% depending on the bore of the oxygen injector. This instrument is especially important when we don't want to give a high concentration of oxygen to the patient. We want to give a decided concentration or minimal concentration of oxygen. And this is important for patients with chronic obstructive airway disease. The high flow of gas into the face mask results in constant inhaled concentration of oxygen despite of changes in the patient ventilation. This is a picture of Venturi. See, we have 24, we have 28, we have 31, 40, 35, and 50%. Those different Venturi it's made of plastic and we can connect as need to this face mask and it will give us the oxygen concentration that we need for this patient. Thank you. This is the end of airway evaluation and management lectures. And I am ready for any question.